Hello, and welcome to the Quality Measurement Development Primer. I'm Melissa Castora-Binkley. I'm a health services researcher here at the Health Services Advisory Group. This presentation will be more general to measure development overall and less specific to any particular contract or project. There are many aspects to measure development, many more than we will be able to cover during this presentation. However, this information should provide you with initial exposure to the development process. These slides can be used as reference material as you move through the measure development process in your contract or project. The presentation is organized by chapters. Today's discussion will begin with Chapter 1, a high-level view of CMS, who they are, and introduce the CMS quality strategy, which guides our efforts in measure development. Chapter 2 will provide a briefing of quality measurement basics. And finally, Chapter 3 will review the process of measure development. Chapter 1, the Centers for Medicare and Medicaid Services and the Quality Strategy. We will begin today by discussing the Centers for Medicare and Medicaid Services, also known as CMS, and review the CMS Quality Strategy. The Patient Protection and Affordable Care Act of 2010, commonly called the Affordable Care Act or ACA, seeks to increase access to high-quality, affordable health care for all Americans. The ACA requires the Secretary of the Department of Health and Human Services to establish a national strategy for quality improvement in health care, which is referred to as the National Quality Strategy, not shown here on this slide, but sets the priorities which guide our efforts. The CMS Quality Strategy, which is shown on this slide, pursues and aligns with the National Quality Strategy. The 6 goals of the CMS Quality Strategy are in the outer ring of the graphic. In addition, there are 4 foundational principles found in the inner ring of this circle. These principles are: eliminate racial and ethnic disparities, strengthen infrastructure and data systems, enable local innovations, and foster learning organizations. CMS supports the quality strategy by developing quality measures that address the quality strategy priorities and goals, and implements them through provider feedback, public reporting, and links to payment incentives. Although the previous slide introduced the 6 goals of the CMS Quality Strategy, let's take a look at each one in more detail as these guide every step of the measure development process. The first goal is to make care safer by reducing harm in the delivery of care, sometimes shortened and referred to as safety. The objectives of this goal are to improve support for a culture of safety, reduce inappropriate and unnecessary care, prevent or minimize harm in all settings. The associated outcome is to reduce healthcare-related harms. The second goal is to strengthen person and family engagement as partners in their care. This goal is often referred to as patient and family engagement. The objectives of this goal are to ensure care delivery incorporates patient and caregiver preferences, improve experience of care for patients, caregivers, and their families, and promote patient self-management. The desired outcome is that patients and families are engaged as informed, empowered partners in their care. The third goal of the CMS Quality Strategy is to promote effective communication and coordination of care, often referred to as communication and care coordination. The objectives of this goal are to reduce admissions and readmissions, embed best practices to manage transitions to all practice settings, and enable effective healthcare system navigation, with the desired outcome that communication and care coordination are improved. The fourth goal of the CMS Quality Strategy is to promote effective prevention and treatment of chronic disease, with the objectives of increase appropriate use of screening and prevention services, strengthen intervention to prevent heart attacks and strokes, improve quality of care for patients with multiple chronic conditions, improve behavioral health access and quality care, and improve perinatal outcomes. The desired outcome of this goal are to reduce and prevent leading causes of mortality. The fifth goal of the CMS quality strategy is to work with communities to promote best practices of healthy living, with the associated objectives of partnering and supporting federal, state, and local public health improvement efforts. Improve access within communities to best practices of healthy living. Promote evidence-based community interventions to prevent and treat chronic disease, and increase use of community-based social services supports. The desired outcome of this goal is to promote and disseminate best practices in communities. This goal is unique in that the other goals are more directly focused on patients and patient care, while this goal is broader to encompass some of the community-based facets that influence the care provided and the outcomes achieved. Finally, make care affordable. The objectives of this goal are to develop and implement payment systems that reward value over volume, use cost analysis data, and inform payment policies. The associated desired outcome is that quality care is affordable for individuals, families, employers, and governments. Chapter 2. Quality Measurement, the Basics. Quality measures are tools that help us measure or quantify healthcare processes, outcomes, patient perceptions, and organizational structure or systems. Quality measures typically relate to one or more of the CMS quality strategy goals for healthcare. Let us explore these concepts further. Why do we measure quality in healthcare? One reason is to improve healthcare quality by using an evidence-based approach. Evidence-based in medicine pertains to the conscientious use of certain best practices, those that are based on research, in making decisions about the care for individual patients. Such research suggests that a particular practice or process has shown to be effective in the majority of patients in carefully controlled research studies. Another reason we measure quality is to provide transparency through the public reporting of quality measures. Many quality measures are publicly reported, which enables transparency so that consumers can compare providers along the same dimensions of care. Compare sites you may have heard of are Hospital Compare and Nursing Home Compare. These sites typically use a star rating system, which the public is largely familiar with interpreting. To determine how many stars a healthcare entity receives, quality measures are used to quantify and differentiate performance. In addition to providing transparency, quality measures influence the payment providers receive for healthcare services. This can mean that payments to providers are determined by performance on quality measures. Sometimes, however, payment is not affected, but in other cases, providers can achieve bonuses for performance or have payment reduced or withheld. Another reason we measure quality is to encourage quality improvement. Quality improvement refers to a wide variety of activities and initiatives to improve quality of care. By improving care, providers also improve performance on quality measures. From this perspective, measures drive quality improvement in healthcare. Measures enable providers to track and trend their performance and make adjustments in care. Providers also share success stories as well as challenges. Most quality improvement occurs at a local level, and therefore, sharing success stories and challenges helps to expand the knowledge base of what works and what doesn't to improve quality of care. Finally, we measure quality to monitor processes and outcomes related to how care is delivered. Understanding how different processes and outcomes affect quality is important to quality improvement. The next slide explains processes and outcomes in healthcare. Structure, process, and outcomes, sometimes called SPOs, are aspects of healthcare and therefore also refer to types of measures. Let's take a closer look. Structure is how care is organized. Structure is usually stable elements of an organization and infrastructure that comprise a healthcare delivery system. Examples include the number of hours worked by nursing staff, whether a provider uses e-prescribing and the extent of that use, and the percent of physician practices functioning as a patient-centered medical home. We typically do not focus on structural measures. The aspects of care that we want to measure should be actionable by providers. Process refers to what is done, the actions that are taken, and how they are carried out. These include the interaction between patients and providers. Processes also include interventions and the timing of care, the timing of when that care was received, the timing of processes, and the timing of interventions. Example process measures are documentation of current medications in the medical record, initial antibiotic received within 6 hours of hospital arrival for those with pneumonia, and cervical cancer screenings. Measures that focus on processes of care are often based on evidence-based clinical practice guidelines. Outcomes are the end results of care, not only what happens to the patient's health, but how he or she experiences the care and derives satisfaction. Outcomes include how much patient impairment or disability a patient experiences. With this example, impairment could be measured from the patient perspective or through the clinician's indications by looking through the medical record to determine if the physician has indicated improvement. Examples of outcome measures include percentage of hypertension patients whose blood pressure is under control, the rate of falls with injury, and the percentage of surgical site infections. Then we have the patient experience measures. Patient experience measures are measures that record the patient's perspectives on their care. Surveys are sent to patients to record their experiences with primary care, specialist care, hospital care, and to determine family perspectives on hospice care. When trying to understand how to improve quality and determining where to focus a measure, one must look at the relationships between the various aspects of care. In order to do this, one must have intimate knowledge of how care is provided and each step that is taken in the care process. Structural aspects often influence both processes and outcomes. Processes themselves influence outcomes, and often there are multiple simultaneous factors affecting outcomes. Outcome measures are the preferred measure type. This is because outcome measures represent the end result of care. For example, is the patient well? When developing outcome measures, developers need to provide a rationale for the structures or processes that can influence the outcome. This rationale should be supported by scientific evidence that shows that providers are able to improve the outcome being measured. In other words, that they are actionable. For example, a widely used outcome measure is the readmission measure, which aims to reduce unnecessary preventable hospitalizations that occur within usually 30 days of a prior hospitalization. This measure is used to determine whether the quality of care given during the first hospitalization and the quality of care provided immediately afterward are adequate to keep the patient from returning to the hospital. Evidence suggests that providers can affect rates of readmissions through various interventions, including by enhancing the patient-physician communication, implementing transitions of care programs, ensuring transmission of discharge instructions to the next care provider, assisting patients in scheduling follow-up appointments, and medication management. And all of these are care processes affecting the outcome of readmission. For process and structure measures, the focus of the measure should be on the aspect of care with the most direct evidence to the desired outcome. Although it is important to develop measures most proximal to the outcome, if not the outcome itself, measures are sometimes limited by the available data, which do not always allow for measurement of the desired outcome or process. Let's review the sources of data which affects the way measures are constructed and influence the choice of which measures are developed. We have claims data, which are billing information for the services provided during patient care. There are assessment instruments, and these can be surveys or checklists used by the provider or collected by a third party. There are registries, which are compilations of patient information collected usually by a third-party organization. An example would be the National Healthcare Safety Network, which collects information on infection control adherence rates and healthcare personnel influenza vaccine status. There is also chart abstraction or electronic health records, and this uses the patient records, whether they be electronic or paper, kept by the provider for patient care. And hybrid measures are the combination of any of the above data sources. Also worth noting is that measure developers should avoid developing measures that can be met primarily through documentation without evaluating the quality of the activity. These documentation measures are often satisfied with a checkbox. For example, a completed assessment, a care plan, or delivered instruction denoted by simply checking a box. These types of measures are sometimes referred to as checkbox measures or attestation measures. This slide depicts CMS hospital reporting programs and the associated abbreviations for them. It isn't necessary to know each one, but it gives you an idea of the breadth and scope of the programs that exist. CMS has long played a leadership role in quality measurement and public reporting of quality measures. CMS started by measuring quality in hospitals and dialysis facilities, and now measures and publicly reports the quality of care in nursing homes, home health agencies, and drug and health plans. Beginning in 2012, CMS efforts expanded the quality reporting programs to include inpatient rehabilitation facilities, inpatient psychiatric facilities, cancer hospitals, and hospice. Some of the other settings or programs that CMS measures are displayed here, which are mostly measurement programs for physicians, as well as prescription drug plans, Medicare Advantage, which is also Medicare Part C, and Medicaid programs. CMS is transforming from a passive payer to an active value purchaser by implementing payment mechanisms that reward providers who achieve better quality or improve the quality of care they provide. CMS has been seeking to transition from setting-specific, which provides narrow snapshots of quality, to assessments that are broader-based, meaningful, and patient-centered in the continuum of time in which care is delivered. The Medicare Access and CHIP Reauthorization Act, also known as MACRA of 2015, will combine some of the programs for clinicians listed above into one new program called Quality Payment Program. As you can see from these slides, most quality reporting programs are still setting-specific, or in the case of ESRD, disease-specific. On a side note, ESRD is one of the only 2 disease-specific conditions for which one can become eligible for Medicare. Otherwise, people generally qualify for Medicare benefits through a combination of work history and age. Other ways to qualify include spousal benefits or receipt of Social Security disability. There are a number of dimensions of measures that need to be determined during measure development, including the numerator, denominator, exclusions, calculations, and the data sources and collection instruments. The simplest performance measure is a numerator-denominator equation that measures compliance. The denominator is the number of times a provider had the opportunity to provide an element of recommended care to a patient, whereas the numerator is the number of times that the care was actually provided. Let's take, for example, a measure, cervical cancer screening. In the denominator, one must specify that the measure is targeting women, ages 21 to 64 years, during a measurement year. Exclusions for this measure are women who had a hysterectomy. The numerator for this measure are the number of patients in the denominator who received one or more Pap tests during a measurement year. On a side note, there has been a change in clinical practice guidelines that will affect this measure, and updates are likely to occur to the specifications of this measure and any measure where clinical practice guidelines are altered or updated. Chapter 3: The Measure Development Process. Let's first review the principles of quality measures. Measures should reflect evidence-based processes or outcomes and address a known quality problem. These ideas will be repeated over and over throughout the discussion of measurement development. The process of measure development is largely guided by the Measures Management System Blueprint. The blueprint documents a set of processes and decision criteria used by CMS to oversee the development, implementation, and maintenance of healthcare quality measures. The primary goal of the blueprint is to help measure developers carry out their contracts and produce quality measures that are appropriate for use by CMS. By applying the blueprint processes, CMS ensures that it has a coherent, transparent system for measuring the quality of care delivered to its beneficiaries. A majority of the information in this presentation was derived from the blueprint. The blueprint is available to the public on CMS's website. These are the stages of a measure's life. Measure conceptualization refers to developing the evidence base for new measures and defining the basic elements of a measure concept. Measure specification provides the technical instructions for how the measure is to be collected and implemented. Measure testing includes both alpha and beta testing, which completes the development stage of the process. After development is measure implementation. Measure implementation includes the submission of a measure to the National Quality Forum for endorsement, the CMS selection of the measure for use in Medicare programs, and measure rollout. Finally, there is measure use, continuing evaluation, and maintenance to ensure that the measure continues to add value to quality reporting programs and that measures are up to date with the latest research and guidelines. Although these are the general life cycle stages for measures, progression through the stages is not as linear and orderly as the graphic implies. Actual development, for example, involves moving back and forth between measure specification and testing, and evaluation of measures in the last stage may result to returning to earlier stages of the process. Let's take a deeper look into each stage. Measure conceptualization. The evidence base for a measure concept and basic elements of the measure are generated in the measure conceptualization phase. Information gathering is the first step in the development of new measures. Information gathering is a broad term that includes an environmental scan, which includes literature reviews, reviewing clinical practice guidelines, and conducting interviews and other related activities, and when possible, conducting empirical data analysis. As shown on this slide, information gathering activities are conducted throughout the measure conceptualization phase to obtain information that will guide the development of measure concepts as well as the prioritization of topics. The gathered information also provides information for the measure specifications and initial business case for why the costs and effort to collect the data and compute the measure are worth it. Sometimes developers will work on developing a set of related measures so that the information gathered for one measure concept also serves for another. To organize information, the measure developer creates a conceptual framework informed by a variety of sources, including research articles, the Federal Register, white papers, and technical papers. The conceptual framework should be broad enough to incorporate any range of measures, but specific enough to be relevant to the specific reporting program. Often at HSAG, we will use the CMS quality strategy as part of the conceptual framework to ensure that our efforts are aligned with national priorities. Based on the information obtained, the measure developer identifies whether any existing measures may be adapted or retooled to fit the desired purpose. To do this, a wide range of resources are searched for measures that exist applicable to this focus. Once a sufficient breadth of information is collected regarding the measurement program and the associated existing measures, an exercise to determine where there are measurement gaps is conducted. By identifying gaps in measurement, we are able to make a statement of need that helps justify the development or retooling of a measure. This exercise is referred to as a gap analysis. The purpose of a gap analysis is to identify measure types or concepts that may be missing from a measurement program, which will assist the focus of measure development activities. If no existing measure is found that matches the desired need, the measure developer works with a technical expert panel to develop a new measure, sometimes referred to as a de novo measure. Once it has been determined that an existing measure should be retooled or that a new measure should be developed, a business case is created. The business case documents the anticipated impact of a quality measure by predicting the return on investment of the resources into developing and implementing measures. Returns on investment apply to lives saved, costs reduced, complications prevented, clinical practices improved, and patient experience enhanced. Also part of this stage is public input. Stakeholder input is a key process to ensure that measures are developed that are effective for accountability, for quality improvement, and are useful to consumers. At this point, the developer has a better understanding of the focus for new measure development, and more information is required to hone in on which measure concepts should be prioritized for development. The basis of this stage for information gathering is on evidence. So what information should be gathered to build an evidence base for a measure concept? Determining the impact is important. Such information to inform impact are the number or volume of patients affected by reporting incidence or prevalence rates, disparities in population health, that is, one group having more or less favorable outcomes than another, consequences to patients or society, for example, indirect costs from wages or salaries lost when ill, and the major benefits of the focus of the measure, for example, heart attacks not occurring, or hospital length of stay decreased, and the expected magnitude of benefits, including specifying how the measure meets the needs and concerns of consumers or patients, untoward effects of the focus of the measure and the likelihood of their occurrence, high resource use, that is, the cost of care or the cost of consequences associated with poor care. This could be the cost of implementing the measures, the cost of the clinical processes, or savings from preventing complications, preventing unplanned readmissions, and improving health. Performance gap. It should be specified that there is a performance variation between the units of analysis that the measure is using, or less than optimal performance. Can a measure detect a difference between high performers and low performers? If there isn't a performance gap, this might not be possible unless the measure focuses on less than overall optimal performance. Sometimes we don't know this information at this stage, but these are the areas to focus to build the evidence base for the measure concept. Further along in the measure development process, each proposed measure will eventually be evaluated according to measure evaluation criteria set forth by the National Quality Forum, also known as NQF, which sets the industry standard, and these criteria guide the measure conceptualization process. Therefore, the information collected should consider the following: importance to measure and report. Is this a high impact of healthcare? Is this an opportunity for improvement in quality? Is there evidence to support the measure focus? Scientific acceptability of the measure properties. Is the measure reliable, valid, and adequately specified? Feasibility considerations include data availability, accuracy of the information in the data, maturity of the clinical practice guidelines, standard vocabularies, and the extent to which data are collected as part of the normal workflow, and that the measure specifications and calculation logic are able to be specified. Usability and use. Consumers, purchasers, providers, and policymakers can understand the results of the measure and are likely to find them useful for decision making. So what is the business case for the measure? A business case will speak to the predicted return on investment of resources in developing and implementing measures. That is, returns on investment can be defined as lives saved, complications prevented, clinical practice improved, reductions in mortality and morbidity, improvements in quality of life, person and caregiver experience enhanced, and more affordable care through cost savings. By documenting the potential improvement anticipated from implementing a specific measure, the measure developer can make a strong case explaining why CMS should invest resources in the development of the specific measure and its quality initiatives. As described earlier in the information gathering process, a demonstration of quality problems and an opportunity for performance improvement is necessary for a measure to be implemented in a program or setting. Therefore, the business case should explicitly outline either considerable variation in performance or overall less than optimal performance. In later stages of measure development, the business case should be updated when there's an opportunity to provide data to add or modify the initial business case information. Also included in the business case is information related to measures that are similar to the one being proposed, which has been identified during the existing measures search of the information gathering process. The business case will answer the question, are there similar measures in existence under development? Measures are considered competing with one another if they attempt to measure the same focus on the same population. For example, the focus is on readmissions and the population is pediatric patients. Since a pediatric readmission measure already exists, a new pediatric readmission measure would need sufficient justification as to why another one is needed. Without such justification, a program could just adopt the existing measure for measuring pediatric readmissions. Measures are considered related if they have the same focus but different populations, or the same population but a different focus. Here we can use our example of readmissions, where one measure focuses on pediatric patients and another measure focuses on adults. These are related but not competing measures. Related measures can be used to compare and contrast measure specifications for the purposes of harmonization. Harmonizing measures refers to defining measure elements so that they are uniform or compatible. Using our readmissions example, we might choose to harmonize the time frame for readmissions, for example, 30 days from the prior hospitalization. To the extent possible, measure developers are to avoid developing competing measures unless justified. After the business case is constructed, the next step is to present the business case to stakeholders to gain their input and insight on the proposed measure. The question to ask at this stage is, what do a broad range of stakeholders, including patients and caregivers, think about the importance and potential use of the proposed measure? Often, the measure developer will ask stakeholders how they feel about the importance of the measure, the feasibility of the measure, and whether there is evidence to suggest that providers can improve performance on the measure. Stakeholder input is often achieved by convening a technical expert panel, or a TEP. The TEP is composed of various subject matter experts and stakeholder groups, including patients and caregivers. Smaller work groups may be convened for specific purposes, such as coding specifications, which then report back to the larger technical expert panel. TEP members are chosen based on their expertise, personal experience, diversity of perspectives, background, and training. The membership should also reflect geographic and organizational diversity, as well as a variety of organizational types that may have an interest in the topic. Specifically, for measure conceptualization, the TEP gives input on the measure topics and their importance. They help refine the candidate measure list. They apply the evaluation criteria to the candidate measures and assess the feasibility of the measures. The TEP is convened multiple times across the lifespan of measure development. It should be noted that the TEP is convened by the measure developer, not by CMS. During early TEP meetings, the members will be asked to review the results of information gathering activities and to clarify measure concepts. They will be asked to evaluate the list of potential measures and narrow them down to candidate measures. During subsequent meetings, the TEP will be asked to review and comment on the draft measure specifications, review public comments received on the measures, and evaluate measure testing results. In keeping with the overall goal of CMS to assess the quality of healthcare in ways that are meaningful and patient-centered, patients' input must be proactively integrated into the development of measures. CMS has firmly asserted that listening to patients' voices and those of their caregivers is a core mission of its quality strategy. Patients and their caregivers are uniquely qualified to provide input regarding measure topics or concepts based on their experience. Patients can help identify issues that are important to them and that they will find useful to better understand the quality of their care. To the greatest extent possible, this participation should involve actual patients and caregivers, not just the organizations who represent them. Early involvement of patients and caregivers is helpful to understand what health and quality of care issues are of greatest concern to patients, and to understand what patients feel is worth measuring and evaluating. In a recent survey of patients and family caregivers who participated in expert panels for measure development, most stated that they would do it again and would recommend participation to other patients and consumers. They felt that they were listened to by the other experts and that their input was valued. Measure specification. At this stage, we should know exactly what measure is under development and know which aspects of the measure should be harmonized and which need defining and refining. The technical specifications of measures are highly specialized and should be guided by subject matter experts with intimate knowledge of the setting, condition, coding, and collection of data. Measure specifications include defining the target population to whom the measure applies, or the denominator, identifying those from the target population who achieve the specific measure focus, that is the numerator, the target condition, event, or outcome. Measure specification also refers to determining the appropriate measurement time window, detailing exclusions, risk adjustment or stratification, other definitions, data sources, code lists with descriptors, sampling, and scoring and computation of the measure. The quality measure also includes data collection instructions, and those pertain to the data source, that is, whether the data comes from claims, registry, chart abstraction, or electronic health records, and when, how often, and where the data are collected. Specifications are influenced by literature, existing measures, TEP input, subject matter experts, public comment, alpha testing, and beta testing. Measures must be specified with sufficient details to be distinguishable from other measures and to support consistent implementation across providers. Also, part of the measure specification process is defining the scoring algorithm. The scoring algorithm is applied to the data elements to compute the measure score. Let's take a look at some of the types of scoring algorithms. There are all or none measures. Let's take the patient as the unit of analysis, for example. Only those patients who received all the indicated processes of care are counted towards the measure. Performance is defined by the proportion of patients receiving all the specific care processes for which they were eligible, and no credit is given to patients who receive some but not all of the required items. The advantage of this type of scoring algorithm is to promote a high standard in excellence. There are also linear combinations. These can be a simple average or weighted average of individual measure scores. The advantage here is that we have the advantage of simplicity and transparency. Regression-based composite performance measures are a high-level type of scoring algorithm. For example, if a certain outcome is regarded as a gold standard, the weighting of individual items may be determined by empirically optimizing the predictability of the gold standard endpoint using regression-based analyses. We also have opportunity scoring. Opportunity scoring counts the number of times a care process was actually performed, divided by the number of chances a provider has had to give this care correctly. Unlike simple averaging, each item is implicitly weighted in proportion to the percentage of eligible patients, which may vary from provider to provider. Measure testing. After the measure concept has been identified, justified, and prioritized through the measure conceptualization phase, and the measure specifications have been defined, it is time to test the measure. Measure testing enables a measure developer to assess the suitability of the technical specifications of the measure and acquire empirical evidence to help assess the strengths and weaknesses of a measure. Testing is also used to assess measure feasibility, which refers to determining the extent to which the required data are available, are retrievable without undue burden, and the extent to which data can be implemented for performance measurement. There are two stages to testing a measure. Alpha tests, also known as formative tests, are of limited scope since they usually occur before detailed specifications are fully developed. Alpha testing supplies information that demonstrates the feasibility of the measure's implementation and may be conducted as part of the information gathering through empirical analysis. Alpha testing may also be performed concurrently with the development of the technical specifications as part of an iterative process. The alpha tests include methods to determine if an individual data element is available and if in the form in which they exist is consistent with the intent of the measure. The second stage of testing is beta testing. Beta testing, also called field testing, generally occurs after the technical specifications have been developed and is usually larger in scope than alpha testing. In addition to gathering further information about feasibility, beta tests serve as the primary means to assess the scientific acceptability and usability of a measure, as well as to augment previously obtained information on the importance and feasibility of the measure. During beta testing, it is important to use a variety of types of settings to test a measure. For example, if a measure is being developed for acute care hospitals, it would be important to test the measure using a for-profit and a non-profit, a teaching and a non-teaching hospital, a large and a small hospital, an urban and a rural hospital. The better the diversity of facility types, the better understanding the developer will have of any barriers or limitations associated with the measure. Scientific acceptability of a measure refers to the extent to which the measure produces reliable and valid results about the intended area of measurement. These qualities determine whether the measure can be used to draw reasonable conclusions about care in a given domain. Reliability testing demonstrates that the measure results are repeatable and the measurement error is acceptable, producing the same results a high proportion of the time when assessed in the same population in the same time period. In measure development, the term validity has a particular application known as test validity. Test validity refers to the degree to which evidence, clinical judgment, and theory support the interpretations of a measure score. Stated more simply, test validity is empirically demonstrated and indicates the ability of a measure to record or quantify what it purports to measure. Now the measure is identified, justified, and prioritized. The measure has been specified and tested. It is time to begin the process towards measure use. Measure implementation is the stage between the confirmation that the measure is scientifically acceptable and the use of a measure in a measurement program. On this slide, we see various entities involved in measure development. The National Quality Strategy often sets the priorities for the development activities that occur. Measure developers and stewards develop and test measures. The term measure steward hasn't been introduced yet and simply refers to the entity responsible for keeping a measure up to date after it has been developed. After the development of measures, there is a series of activities that occur, usually but not always, prior to measure use in a program. Measure implementation refers to a measure being implemented in a new program or added to an existing program. The National Quality Forum, or NQF, is a not-for-profit, nonpartisan, membership-based organization that works to catalyze improvements in healthcare. NQF ensures that the measures it endorses are developed with the highest rigor and scientific grounding. CMS gives preference to measures that are already endorsed by the NQF or are likely to become endorsed for implementation in its programs. Therefore, measure developers should develop measures that meet the NQF evaluation criteria and are likely to be endorsed if they are submitted for endorsement. Endorsement is considered the gold standard. Each proposed measure submitted for NQF endorsement typically undergoes rigorous evaluation during the development process to determine its value and soundness based on a set of standardized criteria, which you should recognize based on the things we've discussed so far. NQF evaluates the importance of scientific acceptability of the properties of the measure, feasibility, use and usability, and harmonization. Measure evaluation is an iterative process to build, then strengthen, justification that the measures will impact an important healthcare quality need, are scientifically sound, and can be implemented without undue burden, and are useful for accountability and performance improvement. NQF has adopted a 3-year schedule for measure endorsement in 22 areas such as cardiology, neurology, perinatal care, and infectious disease. To respond to new developments that signal a need for updated standards for patient care, NQF has a process to consider endorsement projects that fall outside their 3-year schedule. The Measure Applications Partnership, known as MAP. The Patient Protection and Affordable Care Act, or ACA, of 2010 required that the U.S. Department of Health and Human Services implement an annual federal rulemaking process to provide multi-stakeholder group input on the quality measures being considered for public reporting and performance-based programs. MAP was formed in 2011 to serve as the multi-stakeholder entity to serve the role of providing recommendations on the measures under consideration by the U.S. Department of Health and Human Services. Around the second quarter of each year, through a call for quality measures, CMS begins the annual pre-rulemaking cycle of collecting and compiling measures under consideration. In late April or early May, stakeholders are invited to submit proposed quality measures. Following submission, the pre-rulemaking process includes providing the opportunity for stakeholder groups to provide input to the Department of Health and Human Services on the selection of quality measures. The NQF is the entity that convenes the MAP in December of each year to review and comment on the measures proposed on the annual Measures Under Consideration list. This list is sometimes called the MUC list. MAP considers balancing the needs and the goals of an individual program with the goal of alignment. The MAP recognizes that not all measures will be right for all programs. Rather, a measure may address a critically important issue for one program or setting. The MAP considers balancing the goal of alignment with the need for innovation. The MAP considers the need to weigh the benefit of alignment against the benefit of a new measure. Annually, the MAP work groups meet to provide program-specific recommendations to the Department of Health and Human Services by February 1st. For example, the MAP 2014 recommendations on measures for more than 20 federal programs gave input on 231 unique measures that were submitted for potential use in the Medicare programs. After considering the feedback provided from NQF and the MAP, CMS selects measures for potential inclusion in rulemaking. The next steps in the cycle are the proposed rule and the final rule. Finally, after the inclusion of a measure is outlined in the final rule, the measure is slated for use in a program. Measure use, continuing evaluation, and maintenance. To help CMS ensure the continued soundness of the measures, the measure developer must provide strong evidence that the measure continues to add value to reporting measurement programs and that the measure construction continues to be sound. After the measure goes into use by a program, every aspect of the measure is evaluated. The measure steward, which is the entity responsible for the measure, reviews the importance, the aspects of care included in the specifications to ensure that they are continued to be highly important to measure and report. Performance are the measurement results driving significant improvements in healthcare quality and health outcomes. The measure specifications, the data elements, codes, and parameters included in the specifications to ensure that the best ones most accurately and clearly target the aspects of the measure that are important to collect and report, and that they do not place undue burden on resources in order to collect the data. The calculation methods included in the specifications to determine if they remain the best, reflecting a clear and accurate representation of the variation in the quality of the care delivered or the variation in health outcome of interest. In order to make these determinations, the measure steward stays up to date with scientific literature, best practices, and clinical practice guidelines. The measure steward monitors publications for any mentions of unintended consequences of the measure, and the measure steward analyzes measure data for trends and keeps up with changes in coding that affects the measure. Each measure undergoes an update at least annually and a rigorous comprehensive reevaluation every 3 years to assess its continued value based on the same set of standardized measure evaluation criteria used in development that we reviewed previously. Now I'd like to congratulate you on completing the Measure Development Primer and encourage you to refer to these slides throughout your time and efforts in measure development. Please feel free to reach out to me with any questions or comments you may have.